Persons, I once again thank. This is my favorite topic. This is my close to heart. I did RIRS for 20 years and slowly I started doing 5 to 10 years babies. Now I am doing infant babies. We have a series of infant babies and I have published in various papers, and nearly 6 publications are there. The smallest baby I have done is a 4 months baby. So with this introduction, I like to talk on the infant RIRS tips and tricks. When it comes to the infant, any surgery for stone is dangerous except ESWL. ESWL is the treatment of choice. But the problem is, you need anesthesia, you need stenting, you need small, the generator applied to the baby, and it is difficult to monitor with CM. Lot of CM usage is used. Ultrasound machines are less often used, making all these look for alternative is PCNL. PCNL, if everything goes well, mini pack, 12 French, 15 French, fine. But you can't do 30 French in children, 7 centimeters kidney, 6 centimeters kidney. The message is bleeding in children cannot be tolerated as much in adults. Even 500 ml of blood loss can be detrimental, can lead to morbidity, mortality. Then RIRS came. But the problem with RIRS is small ureter, small urethra, male, infant, small urethra. Ureter can be dilated with stent, but urethra cannot be dilated. If you damage the urethra, it is your signature on the urethra that Chandra has damaged the urethra. Lifelong it will be there. So urethra in infants, male, is limiting factor for RIRS. Ureter, post-stented cases, it's okay. So the literature says that RIRS is slowly establishing up to 15 millimeters to 20 millimeters. But as I mentioned, in children, ESWL is still the first treatment of choice. So coming to this is the picture in the present EAU guidelines that RIRS is slowly included for everything up to 2 centimeters. And how different it is from adults: anatomical aspect, workup, technical aspect, instruments, post-operative care, follow-up. So anatomical aspect is, if you look at the urethra size, it is 3.75 mm. That means it is equal to 9 French. If ureteroscope 6 by 7.5 goes easily in the urethra, it's okay. 6 by 7.5 not in the ureter, in the urethra. Or 10 French catheter goes easily. If you have doubt, one day before you put feeding tube of 8 French, next day you can do safely RIRS in male. In female, you can dilate slowly up to 12 French. But in male, no dilatation, except meatus. No dilatation of the urethra at all in infants. Now bladder, in no time when you are doing RIRS, it fills. 30 ml, 40 ml bladder will fill. If you don't recognize, it will lead to rupture or ascites. Ascites is very common. So you should not drape the patient completely. You keep the abdomen open, feel it in the beginning, and every 5 minutes you keep an hand or you empty. Now coming to the ureter, it is usually the length is less, diameter is less, usually 3 French lesser than adult. So you have to stent all cases in infants. One additional general anesthesia will take, but it will be short general anesthesia, no intubation. just put stent, come out. In 4 hours discharge. Second time, when you do the surgery, when you do completely powder in RIRS, you don't require stent. You can avoid post-procedure stenting. But pre-procedure stenting is must in infants. Now, evaluation, don't use the CT more often. If you use only loin, limited cuts, no high frequency the radiation, just enough to get the information. And metabolic workup, I am not going into the details. Stone analysis is must. At the end, small piece with basket you have to take out and send for analysis, mandatory. After the stone is cleared, you go for metabolic workup, not before. That I am not going into the details. Better to have this table if you are doing pediatric RIRS on your OPD table, so that you can see when the patient is getting discharged and write down these parameters so that you remember. Otherwise, difficult to remember. Now, technical aspects, low tidal volume. Normal tidal volume for the adult male is 400 to 500, but they keep it 150 to 200. Normal respiratory rate we keep in adult ventilatory when the anesthetic is around 20, but in children you have to keep a little low. So low respiratory rate, low tidal volume may increase the CO2, so you have to stop in between and do it. Anesthetist will say once it is above 50, stop it. He will hyperventilate, and then after 5 minutes you start the case. Don't keep on doing it. And coming to these are the values per kg body weight, 8 to 10 ml versus 5 to 8, 20 to 22 versus 10 to 14 in children. ETCO2. See, when you do stent removal, you should do no role of cystoscopy in infant. No role of cystoscope, only ureteroscope with triprong forceps carefully removed. Urethra is very small. In no time you enter the bladder. So don't perforate with ureteroscope, because ureteroscope length is long, penis is small. You have to work like laparoscopy. So be careful. And when you baby position, no stirrups, no lithotomy, it is only separation of the legs and just put pads. We regularly do this. It takes 5 minutes job, properly pad it. And then when you do meatal dilatation, in females it's okay, but in males you do only navicular fossa dilatation, just enough to accommodate your flexible scope and ureteroscope. Now coming to the ureteroscopy, this is the most important step. 6 by 7.5 ureteroscope in the urethra. Very large veru will be there, large veru. You go into the verumentorum, you think that you are in the bladder. That is the common mistake we do. You have to bend and go into the bladder. Don't go into the verumentorum. That is very, very important in this thing. Ureteroscopy post-stented is mandatory with guide wire, not without guide wire. And this is parking 2 guide wires at a time. You use 0.018 and 0.032. One for access sheet, one for just parking outside the access sheet, so that at the end you can put the stent safely. So 2 guide wires is better. Sheathless RIRS, not difficult, it is easy. You just pass over the thick guide wire, 0.032. But you have to use merge maneuver. The ureter will be kinking at the upper ureteric folds. You press the subcostal region tightly, it immediately goes. Then don't come back frequently. Just stay there, finish the case. And if you want to empty the bladder, in males only one option, you put suprapubic aspiration with cannula, intravenous cannula, but one person has to sit by the side of the table and continuously aspirate. What happens? After some time this cannula bend and clotted, and you have to take another cannula, put it. But the person should be sitting there continuously watching. The outflow of the urine which you are flushing is through the bladder in sheathless RIRS. So don't take chance. you will infuse 400 to 500 ml of one case of RIRS. If it is not coming out, disaster for the infant kidney. It will. The studies have shown that DTPA scan done after 3 months shows decreased function and future fibrosis. So no question of raising pressure in infants. And bladder drainage in females, you can put a feeding tube by the side of the flexible scope so that it will drain. If you are using access sheath, these are not necessary because you will do half an hour, 15 minutes, come out. Now coming to the ureteric kink, when the ureteric kink is there, these are the Dietz folds which are normally present in children. As you age, as the height increases, they straighten up. So like this, it will be there. You should be very careful. In no time you can perforate. Once you do perforation, after that negotiation is very, very difficult. Very, very difficult. See, this is a match maneuver. Whenever there is this entire draping of the abdominal wall, don't do, so that you have free access. Small abdomen, you hardly you have anything to drape there. Now coming to the initial RGP, it is up to you whether to do RGP or not. I don't do regularly. I directly go. But if it's a bifid system, RGP is very essential. If you are using the basket, a small fragment. Now the latest literature says visible fragment is enough for stone analysis. Don't take a big piece and get into trouble in the ureter. Now coming to the RGP at the end is must. Intravasation, extravasation can be seen so that you can put the stent for a longer time. And coming to the, it's not moving, yeah. See, this is a picture. Within 1 minute of RGP, contrast has perforated the calyx and gone outside. This is 9 months baby. Supine PCNL is done. This is one of the smallest baby literature we reported. But you should know both procedures. You can't say, I cannot put PCN, then do RIRS. No. At any given point of time, if the PCS is injured, you should be able to put the PCN. Otherwise, it will go to mortality range. Very, very risky is to go a child into sepsis because they don't manifest with pain and all that. You have to be very careful. Now this is a stenting. We use 3.5 French loaded with 0.018 thermo guide wire through the ureteroscope, which is kept in the ureter. Guide wire acts as the pusher and then come out. Most of the times length will be too much. Even 14 centimeter length is too much for the kid. So you coil more in the kidney than in the bladder. It irritates. That is another important point. Post-operative care is different. TLC is not very good. C-reactive protein is better. And respiratory rate, temperature, ESR are very, very important than total leukocyte count. And follow-up should be by biochemical analysis, preventive measures, comprehensive workup, ultrasound yearly. We have done many cases. We published along with Kemal Serika sir. We are writing up now World Journal of Urology tips and tricks in infants RIRS, and no mortality so far I have seen. No mortality, no stricture, because we quickly convert to PCNL if we have any problem. We don't continue with RIRS. Within 5 minutes, we will decide. And we don't have any problem. So there is a lot of review of literature available with our own papers. Now videos I will show. This is the smallest baby that is done with RIRS bilateral, 4 months. A small baby from the pediatric referred to us. We stented. One side we have done. Lot of kink was there. So with the merge maneuver, we went inside. Multiple mug was there, small stones. So with the merge maneuver, we went inside. Multiple mug was there, small stones were there. But in the present era, we got 6.3 French huge med scope. Yesterday we used in our conference, as Professor Isam has given to me. That's very useful. Very, very useful. Particularly, no conflicts of interest, huge med. The thinness is like ureteric catheter. So this is on one side, then you go to the other side, and the same steps will be repeated. And baby is now 2.5 years, doing well. We publish this. And this is 1 year baby, RIRS, very straightforward. In females, slightly easy. when you do without access sheath, movements won't be transmitted so easily in the inferior calyx. When you use access sheath, they are better. So you should keep this in mind. But one advantage in children is total PCS is not very complex. It's small. You can go to upper calyx, middle calyx, lower calyx in no time. The angles are not deep. The length of the calyx is not deep. Everything is small. So visibility of all these stones is quick. So you can quickly finish the case. This is 1 year baby, 2 years baby, sheathless RIRS. We have done around 80-90 cases of less than 2 years. If you compare, more than 5 years is almost like adult. But 1 year, 2 years babies, it is difficult. When you go above 5 years, it's fine. Penis is big, urethra is okay, stent is okay, stentless is also okay. But less than 1 year, you have to stent in all the cases. Otherwise, in the literature, commonest side effect is perforation. Second commonest side effect is stricture. Third is intravasation and extravasation. Fourth is sepsis. In our series, commonest problem we face is the fever. Post-operatively, 46% fever, but all the fevers are not sepsis. Second day, third day after changing antibiotic to piperacillin tazobactam, we are able to get out. So now the small caliber access sheet is coming. Now we are doing fans also, but you should be very careful because fans length is 50 centimeters. Now the clear Petra has produced 35 centimeter sheet better, but in children you require 25 centimeter fan sheet. Otherwise too much outside it will be hanging, very difficult. So casually should not be attempted. This is the smallest first, this is the smallest access sheet. Even smallest 8.5 access sheet has come into the market. Everybody is producing in India freely. All local companies are producing. We are using it and we are able to do it. This is the fans. Last video I wanted to show. We pass access sheet carefully over the thick guide bag. Whenever it enters to the PCS, acute angulation will be there. Don't push. This is the access sheet fans. It will go nicely into the kidney. Every drop, every molecule of the powder will be sucked out. Vision will be very good. You suck, you start. You suck, you start. So it takes very fast and large stones can be done. See, this is at the end. You don't see any harm. But stenting is mandatory. So with this, many cases are there. To conclude, it is feasible. And it's okay, I don't say very safe, but for 20 years I am doing RIRS, for last 7 years I am doing children, last 5 years now I am a referral center for infants. So I get monthly 2 cases, but that case I will not give to anybody, not my team. I have 11 urologists, even guide wire stent removal I will not give, I only will do it, because they are very precious cases. SFR is comparable to P7, it is less hospital stay. Sepsis risk is lowered by suction, less radiation exposure, no doubt. Multiple anesthesia sessions is the major disadvantage. So I once again thank you for giving this opportunity.
Any question from the floor?
Thank you, Dr. Chandra, for tackling this difficult case in a difficult situation. I have some experience in managing children this age doing minimally invasive PIL. I think the problem is with the instrument. You have to have a good set of miniature scopes to tackle these stones. This is number one. My question to you, how do you counsel the guardian, the father and the mother? You tell them, I'm going to go inside, see if the ureter is capacious, and I'll go with the flexible scope, I'll finish. If not, I'll re-stent, then I'll go again in another session, or you tell them that I'll do a PCNL at the same session. So how do you
I understand your question. It's very important for the juniors. for medico-legal purpose,
Yes.
if you are doing RIRS and if you convert to PCNL without informing patient, it is not correct.
Yes.
So in our consent forum, we take consent for both RIRS and PCNL always. So we don't discuss, because child anesthesia is precious. We take the consent for the PCNL, consent for the RIRS. Both.
This session you are going to finish the school,
Whatever. Usually try to finish. Then parents will be happy.
Yes.
If you come out without doing anything, they will be unhappy.
Yes. Thank you.
One more question? Go ahead.
Thanks, Chandra, for this nice presentation. I have a question regarding to pediatric treatment of stones anyway, RIRS or mini PNL. Long time, as a tract usually small or use RIRS flexible ureteroscopy sex fringe, take long time, there is sometimes transudate fluid from the kidney through the very thin peritoneum to enter abdominal. You face this complication?
Yes, ascites I have faced. At the end of the surgery, 1 liter ascites were there, RGP normal, cystogram normal. The fluid transudates from the kidney into the gerotas and then into the peritoneum, and it quickly transudates into the abdomen and abdominal distension happens. I don't cover the abdomen. I will be watching in the beginning, at the end. I have put the drain. This is my 3rd or 4th case. In the initial cases, we do mistakes.
Thank you.
Last question. What are the precautions you approach a stone in a limited renal pelvis? Your irrigation, your parameters of the laser machine.
Yeah. I try to dust the stone in infants because they recur very fast. Dusting, I said standard, 1 joule 10 Hz is the standard with TFL.
I mean, the rupture of the system is very vulnerable.
Yeah, the person who is flushing, Oliver Traxler sir says that if a heavy person is flushing with a heavy syringe, the chances of perforation is more. So 2 ml syringe or 3 ml syringe or by gravity is better. No pump at all. Very slow so that the calyx are not distending. If the calyx distend, water flow stops and then slowly RBC will come. That means you are not doing well. Just take the decision for PCNL and quickly go up. And large stones we don't do. More than 2 centimeter stone we don't do RIRS. Amount of energy delivered is like in half an hour, 1 joule 10 Hz, 10 watts. 10 watts.
Thank you, Dr. Mohan.
Sir, one small request. Can I? For the audience, for those juniors, I got a lot of requests for the fellowship. Just for the information, for the India, any fellowship, it has to go through the National Medical Council. So I have kept already my phone number. We will try to help because a lot of Egyptians are my friends on Facebook. It takes 6 months, it takes 3 months time for the Indian government to clear. If you are board certified, then only you can do the surgery in the hospital. But for observership, 1 month is enough. For observership, there are no permissions, no recommendations. So depending on your need, you can text me because many requests has come. I am announcing. Sorry for that. I thank you once again for the opportunity.
Thank you very much.
Thank you very much.
We move to the next speaker, Professor.